was all I saw your little study with all the books and I'm like, oh, I like that.
Which is funny because my actual office looks a lot like this.
Does it really?
Yep.
Mine does. It's just not that high.
Yeah, I've got like the half bookshelves, but like I
Uh-huh.
have it's just full of books, and then on top is like all my little spooky trinkets, and yeah, it's not black, but it is a dark green in here.
I love it. No, I love when they go floor to ceiling like that.
One day when I am insanely wealthy, I'm going to have a library that has one of those old-fashioned ladders that will roll.
Yes, the rolls.
Yeah. One day I just
I'm
need to either marry wealthy or win the lottery or something.
right exactly. I want that up top, just a library with a ton of books that I can look at, but will only read very few of. 'Cause- And then at the bottom, I want a huge wine cellar just to sit in with wine everywhere. I love wine cellars. They're just so pretty.
Yes, I would agree. They're
You
very
can
pretty.
actually find those bookshelf ladders like you're talking about. One of my previous houses, we had bought them we bought these beautiful bookcases, kind of like the ones in your background, that had one of those ladders on it at American Furniture Warehouse.
Nice.
And, you
That's
had
cool.
to make the ladder work, you definitely had to, use screws and, you know, attach the bookcases to the wall, but it was cool.
I love that. I could live like in a bookstore or a library. Like, I love books.
I do too. I go through phases where I'll sit and read and I'm really good and I'll read and read and read. And then I'm like, I haven't read a book in like a year.
Oh, I just started a new one last night, so I'm constantly reading.
Good for you. I was reading or listening to something about Charlie Kirk, and he read like 100 books a year. I'm like, oh my gosh, it's crazy. They're probably all just having fun. I emailed Scott and told him that you and Jen and I had talked about wanting to come, even though we couldn't get there today.
Yup. Well, and no one's emailed saying they're having problems. I guess we'll just keep waiting. Tasha says she wants a law library. I don't know if I could do a law library.
Yep. I love libraries. I remember the Dewey Decimal System where you had to walk in during your class and you had to go to the card index and find the card and go find the book.
I was watching the original Ghostbusters the other night, and there's that very opening scene where all the card catalogs open and
Yes,
they start flying out. And my mom was like, "Do you even know what that is?" Yes, I know what a card catalog
I
is. Thank you. I
know.
even know how to use it.
I like National Treasure where they go to the Library of Congress. I
Mhm.
went eons ago. I think it was like for a high school trip. We went to DC and got to go to the Library of Congress, and it was just like fascinating. Gone are the days. Libraries, I fear, will be gone by the wayside, kind of like blockbusters. Although they just opened a brand new Barnes and Noble, I was a little shocked in town down here of all the things they put a Barnes and Noble in. I love it.
I would cause so much trouble for my bank account in a Barnes& and Noble.
Me too. And a lot of it for me is stationery and paper and writing stuff, journals,
No,
notebooks, calendars.
I park myself in front of like the horror section because it's not very big. And I just go through and like, which ones do I have to have? Which ones are just going to go on the to be read? I have a bit of a problem of collecting books.
When
So
my boys were little, my husband and I we would go to dinner on date night, and then we didn't want to go home yet. So we would go to Barnes and Noble and get a coffee and go hang out and look at books.
yes, I miss the Borders too. Borders was a nice one.
Yes, yes, yes. Oh my gosh, yes.
Hello, Pat.
Hello.
Is this your phone? Hey guys, sorry. Yeah. So
Oh, we lost you're muted again.
okay. Sorry, we're just setting up
You're good.
the.
Just give me the meeting ID and I can get it set up here.
I probably just plug in.
Go ahead. You can see if it works.
I will let know.
I don't know because I know
Uh-huh.
this is connected to the TV directly, but I don't know about these cables. That's why I was like,
So I just plugged into a random cable.
yeah, probably. Appreciate it.
There though a minute ago. Well, at least this one was.
It says we have a.
Thank you so
Oh,
much.
my background is blurred, so you won't be able to see anyone.
Host is joined. Let them know that you're
That's the meeting room.
joining meeting.
Recording in progress.
Here we go.
Oh, we saw there it is. Can we pin that? There we go.
Ta-da.
Awesome. Sorry for the delay, guys.
Go ahead and mute.
I don't know. We're just glad that you're able to join and we were able to use technology and all the things.
Is this all the person turn out?
I think there probably gonna be some people who roll.
I'm trying to find.
Understand things.
Yeah, I put the signs in the most public spaces for them to see.
The nice thing is you can see if they're lost.
Yeah.
I'm gonna go downstairs and take a look and make sure anybody's.
This is last year's because this yours hasn't been printed.
I see.
Yeah, but the website's fine.
Thank you.
And you guys can hear us okay?
Yes.
Okay, sweet. It's usually pretty good, so.
All right. And
Go
then
ahead.
let's see. It's gonna try and open. So Scott and the people that are in person, I had mentioned at the very beginning, I have to jump out in probably like a 10, 15, because I'm going to be at the Capitol today to assist with questions and answers regarding the competency bill. Let me pull up the agenda. So, sorry, I've got too many tabs open.
Yeah, zoom it out.
You didn't want to be front and center?
Not especially.
All right, so I do have both Taylor and Ashley here to help with some notes, and even though I will be jumping out, they'll still be able to like host the Zoom, and then I'll turn it over to Michelle to facilitate. Let's see if I can.
Is Jen not here today?
No, she told us she wasn't going to be here, and I forget the reason.
That's right. Sorry, it's Monday.
So putting in the chat our minutes and the agenda.
And let me
And
look up.
sorry,
Well-
just because we are hybrid, can everybody who's in the room at some point introduce themselves or just kind of say who they are so that Ashley can log it?
Who wants to do that now?
Yeah, that'd be great.
Jess, Karen, Scott,
I'm Kelly Conkowitz.
Sean Hansen.
me.
So I'm Scott Simpson. If you're not, if you're online, but for the people here, so this is I'm the director for the Division of Community, Population, and Public Mental Health at the C School of Medicine. And so our faculty work across DHS, DOC spaces, in community, and we have partnerships with over 60 locations outside the Anschutz Medical Campus. So for those of you who are in person, having live coffee and scones, yeah, we'll give a little tour of the offices and some of the Anschutz clinical sites afterwards. And if any of you on the call are ever interested in coming by in person but can't today, always happy to have you. So feel free to send an email. So, okay, that's my.
I'm Karen Rice.
All right, Michelle, you want to take us away? We kind of did.
Yeah,
Overall.
I am noting 3 people missing. Is that correct? So we would have a quorum to do our minutes.
Let's see here. We've got 4 on site plus 1, 2, 3, 4, 5.
Dan, I have Dan listed, but Dan, I don't have your last name listed for whatever reason. Samantha. There we go. Dan and Samantha. We're missing 4, 5.
I think we
But
have a
that still
quorum.
leaves a quorum. Yep. Fantastic. Okay. Um, Scott, thank you so much for hosting this. I am in between trips. Literally, I've been home for 2 days and I leave in 2 days. I could not get to Denver in this middle time, but I think a lot of us would just love to be able to all be close so we could sit once a month in a meeting. But thank you for doing this. And for those of you who made the trip, um, let's see. Would you skim through the agenda, please, and scroll just to make sure no one has anything else to add? And who did you say was taking notes?
We've got Ashley and Taylor today controlling our
Beautiful.
screen.
Ladies, do you have the missing members? Are you good?
I do.
Beautiful.
Yeah.
Okay. Good. Sorry, Jess, can you scroll back up? That's for everybody. Obviously, you made your way to the conference room. Okay, so we're going to go through updates, 2765 updates today. Talk a little bit about moving forward. Does anyone have anything else they would like to add to the agenda
I
for
say, Ashley, can you
conversation?
scroll down just a little bit so that the box is in the center? Right there.
Perfect, right there.
Perfect.
Yep. We're going to do some legislative updates. We're going to get an update on hiring, some of the 2765 staff. And then Jess is going to discuss the competency bill really quickly and then head out.
Pretty
And
much.
we can continue that conversation. And then again, we are going to leave this ECM1 combination topic on the agenda probably for the remainder of the year, just because it's such a big conversation and it's not just with us, it's at the legislative level. So we just want to keep that going. And make notes with each meeting, and then we're going to pull those notes and turn that into our one of the points for our recommendations at the end of the year. Anything else anyone would like to talk about? Hearing, seeing nothing, we're going to go with our standing agenda. Minutes from March. May you please pull those up? Can you please pull those up? And these were sent out ahead of time as well, but we'll have Ashley pull them up or run through them pretty quickly.
And Ashley, if you want to slowly scroll through them so people can take a read.
Casey. Let me see. I'm really, oh, never mind. I'll ask later. Who took those notes last time? Those are amazing. That's exactly what we're going to pull at the end of the year, all those notes. Any questions, comments, additions, amendments, changes? Mm,
I move to
Hearing.
approve.
Say that again.
Oh, I said approve. I move to approve the minutes.
Perfect. Dr. Simpson made a motion to approve. Is there a second?
Dan, second in the chat.
Beautiful. Thank you, Dan. Minutes are approved.
Sweet. Ashley, if you'll click back over to the agenda.
Tasha, did you get that answer? What is the bill? 26-116, 1116?
Yes, I put it in the chat. It's Senate Bill 26-149 is the competency bill.
Oh, no, no, no. She wrote what bill is 26-1116.
Oh, that one
That's
is,
the M1 that did not, no, that's 63.
yeah. So when we are looking at the legislative updates, that 26-1116 also cut everything
Yeah.
to combine, to copy paste, whatever we want to call it. All that ECM1 process was removed. So that bill now just has things around updating the follow-up after an emergency mental health hold from 48 hours to 72 hours. And it's some COC, Certificate of Compliance, issues for outpatient or telehealth providers, kind of behind the scenes licensing stuff. So there's not a whole lot to that bill at this point.
However, that's the one that is going to be, whether they keep the number and the title or they come up with a new one, that is the one that is going to be this continual conversation of ECM1 because this was the start of it. So just so everyone knows, that will be the one we continue to talk about.
And because they
Okay.
cut everything, I suspect what we'll do is we will kind of come up with our own version of it to provide as a recommendation.
Mm-hmm. Yep. I just mean when it goes back to the Capitol, I don't know if it will be an amendment of 26-1116 or if it'll have a whole new.
Typically, it has to have a new number for next year.
I think so, right? Yeah. Oh, that's right. 26 denotes the year. Okay. Minutes approved. 2765 review and updates.
So
Go
I'll go,
ahead,
yeah, I'll go
Jess.
through this pretty quickly just to make sure we have some time to talk more about the competency bill. So we kind of just gave you one of the legislative updates around that 1116 and the removal of anything 2765 minus that 72-hour follow-up change. We've already talked about how the secure transport bill removed all the 2765 pieces. And both CDPHE and BHA are in opposition of that bill. Competency is really the big one. So between the last month's meeting and this month's meeting, that was introduced. sorry, let me do hiring before we get into competency. These are just some really quick updates. So we've talked a little bit before how like Ryan Templeton, who you've all met, was the division director for the legislative affairs team and division. Amy Hickson was the licensing and designation director. Both of them have moved into other positions. So Amy Hickson is now the division director of quality and standards. That's Tom Miller's vacant position. Ryan Templeton is in a brand new position called the governmental affairs director. This is going to be at the same level as a deputy commissioner. So he oversees quality and standards, the legislative team, and the regulatory affairs team. The regulatory affairs team is our team that does all of the rules. They do administrative rules, commissioner rules, and provider rules. So they have quite a haul ahead of them is what I will say. They're in the middle of doing provider role revisions and incorporation of feedback this month, and then they will be presenting those proposals to our attorneys general, and we will present those at state board later this fall. So, okay, competency bill. So this one is known as the pathways bill. You'll hear it referred to because it's about different pathways for people who are permanently incompetent to proceed. So you'll see it's say like PITP quite a bit. And really what it does is it creates some new civil systems and methods, pathways, if you will, to move people from the criminal courts to the civil courts. So we have kind of different buckets of people, populations. There are people who would have like a neurocognitive disorder. There are people who would be have intellectual or developmental disabilities, so our IDD population. And then we have our population who have mental health as their primary, I hate to say disorder, but their primary diagnosis. And so one of the pathways that are currently in existence is the ITP to STC pathway under 2765 108.5. And this is for people who have been found incompetent to proceed. They're either permanently incompetent, or they're unrestorable, they've timed out, but they have a primary mental health diagnosis, and they would qualify for a short-term certification under 2765. So that pathway is already in existence. Some of the other pathways that are new for people who have either neurocog issues or IDD, they have two new pathways that would lead them to the civil system. One of them is protective placement, and the other one is, and please anybody else can jump in at any time because I'm going to butcher it because it's not my area of expertise. It's protective placement and, oh my God.
Civil commitment.
Say that again?
Civil commitment.
Thank you. I don't know why that was so hard to come up with this morning. But yes, and so those have their own court processes and different timelines associated with them that will really keep those systems fairly separate so that we're not commingling, so to speak, these different populations with different needs. There is an addition in 2765-109 that allows for a petition for short-term certification when somebody has been working with like an outside professional person or intervening professional. They have an established treatment rapport where they might not be part of a designated facility, but feel like that person could benefit from some involuntary treatment. So that's another potential pathway. Those are the big pieces. What questions, or anybody else who's very familiar with the bill, what would you like to add?
So it looks like there are actually 3 different pathways there. There's the protective placement, the enhanced protective, and civil commitment. And one of the issues I think with this is that it sounds like 3 separate ones until you look a little further, but it says that if they can't be properly placed, that the Office of Civil and Forensic Mental Health is required to put them in the state hospital.
Yes, and part of the fiscal note with this bill is building more beds, essentially. So the fiscal note is available on the legislative website. Sorry, excuse me. And I'm going to butcher it, but for this fiscal year, so our fiscal year ends at the end of June. There's a $4 million, I want to say, fiscal note for this year. And then next year, it goes up to $100 million. So that's a very steep price tag when we don't quite have the monies available. So that's going to be one of our big concerns when we're testifying today. Let me find it.
And Jessica, can I ask how? And I haven't read through the fiscal note, but is all of that earmarked for inpatient beds versus other community-based programs? Do you have a sense?
Bridges will be getting some of that funding. Thank you, Frank. He put in the link in the chat if you wanted to pull that up. I will download the actual file and drop that in the chat as well.
So page 11 talks about beds.
Yeah,
Yes.
So it's okay. I saw that it came out today, and I just haven't
Just
read it yesterday.
literally.
Okay. Yeah.
Yeah, so a lot of it,
I have to read the original one, and I was like,
yeah, the beds is a big piece of it. But it's not just state hospital beds that they would also need to use some of these monies for. It would also be changing some of our regional centers and increasing their security because right now they're unlocked facilities. So there's some rules and things that would need to be changed about having them be locked. I don't know all the details on that piece, and I'm bummed Samantha's not here. But you can kind of see how it's broken down right now as far as who needs what, which different state agency requested monies. So like BHA didn't request anything for this fiscal year, and we requested almost 800,000 for the next fiscal year, but the majority of it is going through CDHS and OCFMH, mostly for care coordination needs, beds, actual construction needs for different facilities, things like that.
I haven't seen the fiscal note either, but is there any money in there for the community mental health centers to actually do the certs? Because right now we get no money for doing certifications, even though they're extremely time consuming and going to court and so on and so forth.
Let me look at the HICPUF section really quick.
it's like they wouldn't be certs, right? Huh? They wouldn't be certs. It would be this protected.
Some of them will be
There's
certs.
still a lot of certifications.
Yeah, they're
right?
basically
So,
ordering them. I mean, we don't get paid as it is. Like we literally do them.
Yeah.
Or negative dollars. So it's like you're kind of being forced to take these and yet not get paid anything.
that was actually the testimony I sent in on this bill, was that it's an awful lot of requests for services without any actual services being funded.
Right.
Or and requirement that they place people in beds that don't exist.
Yeah. And no enforcement.
And no, yeah, and that's
So I
this
think
is-
those are the biggest issues. I mean, I feel like I get where this is kind of the flavor of this bill, but it's just it doesn't have the infrastructure to really work.
Mhm.
Enforcement, money, facilities. Those are huge.
You know, the state of Colorado is already paying a settlement on the competency wait list. This is just creating an additional wait list for beds that don't exist. Like this is a huge problem.
Absolutely agree. And one of the problems is because there's not like a delayed timeline, it's putting in a system, like you said, that we don't have beds for, we don't have the infrastructure for. It's just putting in a brand new system with no way to actually run it. So I'm not seeing anything in the HICPUF budget that specifically says it will go, there's additional payments for some of these community mental health centers. Their 3 FTE that they requested was to provide care coordination for enhanced protective placement and protective placement individuals.
So lots of unfunded mandates.
Right.
Potentially.
I mean, it's hard because it's like, we want to do what we can to get folks out of these civil systems and, to help, but like it's not going to work, and it kind of sets up the providers to be responsible for things we can't control. And so, the opposition is for that reason, not because we don't necessarily think, or I don't necessarily think it's a bad idea to be trying to help with these big issues. But
And so I apologize because maybe I'm just learning the bill myself. So the concern would be that these short-term certs are coming from the population of patients who are ITP, or they're currently in the judicial system right now. They're ITP, or they're mired in their competency wait list.
right.
And so if they go to the civil system, they'll be short-term
Right, then
certs
the
that you
court
have to-
basically, and that's another issue, the court basically decides, so that
Yeah.
takes away
Right.
clinical decision making, that's a huge one.
Okay.
So that's another, like, that to me is issue number two. You've got courts making decisions, and I know the hospitals are leery of courts telling them they need to be inpatient when that may not be the level of care that's needed. Certainly not necessarily money for that. Could risk, taking people's rights away. Don't meet medical necessity. I mean, on and on.
So there's a whole section in there that talks specifically about how the court can override the Office of Civil and Forensic Mental Health, as well as any clinical diagnosis, if they fear that the public's safety is at risk. And judges are always going to err on the side of caution. So that sets it up for an awful lot of people who end up kind of permanently in the hospital.
Yeah, I think it's really infringes on people's rights.
Agreed. That was one of my big pieces of feedback was this is moving us back towards institutionalization.
Exactly.
And so from the community, so I know like in the bill, and again, I haven't read the fiscal note, but the bill itself, kind of the buck stops with like a lot of DHS. So there are hospital beds, there's bridges, there's regional centers. Does that obviate any of the concerns on the mental health center side? Like if it doesn't fall back to the mental health centers, it falls back to the state, right? It falls back to DHS to care for these patients, right?
Correct. It actually specifically says that they will be put in the state hospital if appropriate care cannot be found otherwise. But in the meantime, they get to wait in jail until there's a bed in the state hospital.
Well, there's other pieces that
Yeah,
also.
I mean, the idea would be that the state has expanded outpatient capacity, right? You're talking about, I don't know, regional centers, outpatient. That's not outpatient, I guess, but regional centers, bridges, like there are other things besides hospital beds. So the expectation would be the state's going to have to do some of this less restrictive care, but DHS is going to have to figure it out. Basically.
Well, one of the big concerns in this is it says like if we can't locate a bed, we could just certify you for outpatient care. Like even if like clinically they need to be inpatient, if there's just no bed available, the court can decide to certify them outpatient, which is really worrisome.
Well, I mean, that kind of stuff happens now, and people end up in the competency. I mean, pathway, which is like why we're trying to get out. Yeah,
right, that's
right.
this was supposed to fix. It was supposed to fix exactly that. Yep.
And I'm speaking from my individual capacity, not from my work perspective, but I believe that the long time frames, I don't know if they'll pass constitutional muster.
Yeah.
It's like 70 days for a jury trial or 60 days for a court trial, and these people are preventatively having their rights taken away. And that's why it's so quick in the mental health world. It's in 10 days. 70 days is outrageous.
Yeah.
And it's actually more than 70 because they can then redo that. I think it's up to 6 months. It's like a ridiculous number that if they don't agree, if they agree to go for the hearing, it can go on forever. But if they don't agree, it's up to 6 months, well, almost 6 months. It's 176 days, I think. Yeah, there's some serious problems with the way this is
And also speaking from my personal perspective as someone who is on an M1 hold only for 72 hours, but still having your autonomy taken away. And I was put into a facility over Christmas where I was seen by one therapist. I didn't know what was going on. I was 19. And so I feel like it made my situation significantly worse having that autonomy taken away. And it made me more depressed and more suicidal. And I had 3 years of like the worst years of my life after it. And so I really need to advocate for the fact that if someone is stuck in the system with their rights taken away, waiting for all of these different components and it's back and forth, that person is suffering that entire time, especially if they maybe didn't need to have their rights taken away in the first place. So, I think any further complication is going to be very bad for the patient perspective.
One thing to add to that too is that there is no requirement in this bill for treatment while in jail because there aren't the beds. And so they're holding them in jail and there's no requirement for treatment, mental health treatment while they're in jail. No. So this is also an additional problem with this.
And you can't force meds in jail, even if they were like on the cert, and then the cert kind of gets dropped, so to speak, when they're in jail because,
Right.
so you have people just languishing there, untreated, waiting forever. It's a horrible situation. So it seems like we're like unanimously opposed to this bill.
So I
Well, I don't know that I don't know that I would include myself in
Okay,
like
yes,
frank opposition because there are some things I don't understand, but
Right.
I definitely agree that they're limited. It's not the panacea.
I think you can request amendment without being opposed. So the amendment needs to be that there needs to be some significant money in this for additional treatment, additional beds, additional help, rather than making it entirely punitive.
Mhm.
So I would say because there is a problem with releasing people who have committed, especially violent crimes, back onto the street, which was what was happening with Pathways. That's the reason for this bill was the young man with IDD who was released and then became problematic again. So there's and that is an issue. It's something that needs to be solved. So I think I wouldn't say I'm opposed to the bill entirely. Just as written, it doesn't hold water.
I mean, I think the additional issue, and I bring this up, seems like every time we meet, is especially with these folks that have already committed crimes, we can't enforce the civil ones as it is. So now it's like we've got dangerous, potentially, folks out there that we're responsible for it, yet we can't enforce anything. So if they don't come to an appointment or they don't take their meds, which is what's requiring them to stay healthy and out of trouble, there's nothing we can do about it. I mean, I think especially a bill like this needs to have enforcement. And I know how far away the state is from, or politically how far off we are from getting the police forces on board with helping in these situations. So it seems like enforcement is 100% needed to make this bill work. Otherwise, you're kind of, in some ways, the courts are turning folks loose, so to speak, thinking there's going to be treatment and everything's going to be okay, but yet there's no way we can force people into treatment, even though in theory that's what these certifications are doing. So I think it also speaks to the lack of awareness of that issue, or a lack of acknowledgement of that issue, of how problematic it is.
But I think you can't force them into treatment because there is no treatment.
There's all kinds of,
there's
right.
not enough. There's
But
not
even,
enough.
even if, for the outpatient service at least, I know that many, if not all, of the community mental health centers would be willing to take these certifications if there was enforcement. That is the reason people don't want to take them. So, as soon as you got enforcement in place, I think you're going to have a lot easier time placing these people in the community versus in a hospital, but that's, the limitation.
And that limitation has been that they've been, the proponents of the bill have been transparent that that's been a limitation. Sorry, this is Frank Cornelia with CBHC. the the folks that wrote it are PDs and DAs, public defenders and district attorneys, and they're very keen on the court process. And so this is, this bill creates these pathways through the legal process to transition from criminal to civil. But I think what you're all talking about has been our frustration, and that's where I jumped in, is that they've essentially said, just take a leap of faith and let's get the treatment. Next year, let's focus on the treatment side. Well, you can't necessarily open all these doors without solving some of the problems we've long identified on the treatment side, which is, I think, law enforcement participation. Just really that, we've been at the table for AOT conversations, assisted outpatient treatment. Just like Karen's saying, like, there needs to be a whole system of care where all stakeholders agree to what the roles are, what the process is, so that there's a system wrapped around to keep somebody in a community, not just provider A, you've got to take them, you don't have a choice, and figure it out, even though you don't have, housing, you don't have, transport or, response to pickup orders, things like that. I think that's been the challenge all along for providers.
And the bill, your interpretation, I guess, Frank, here, the interpretation is that the Pathways bill would compel mental health centers to accept a certification, or
Force even.
yeah. So, because right now it's like I don't have capacity, I don't have people.
Well,
like,
actually, I mean, in theory,
right,
we are. The BHA says we have to take them, but we have the right to refuse because we don't have the ability to enforce them. So it's like beyond what we can do. And Frank, the whole idea of a leap of faith, it's like, is this really the population you want to take a leap of faith with? And what community mental health center is going to be on the hook when that leap of faith turns into a crime? And then there's, potential lawsuits. I mean, I think it's just unreasonable to say that the treatment needs to be set up first in this case, because it's high stakes population.
I'm not familiar with this bill, but I mean, I work with the DOC psychiatrists, and they do everybody who's been like convicted and sentenced to prison. They don't really work with the jail population, but I know that they do like IMEDs, like involuntary medications. Is that an option with this bill? Is that something that can be?
Yeah, absolutely. And if I truly believe these folks can exist in the community.
Okay.
But their stability is so dependent on if they get these medications. And my point is, like, we can't we can't insure them. Like, if they don't come in to get the injection, there's nothing I can do about it.
Right.
So now all of a sudden they're not getting their, medication, and then they decompensate and something bad could happen.
When you say injection, are you talking about like LAIs?
Yeah, exactly.
LAIs.
Yeah, exactly. So.
I think a lot of times the initial part, especially, I have mostly familiarity with really extreme, severe schizophrenia, my daughter and others. So that population needs inpatient care for a while until they're stabilized. And inpatient care doesn't exist. And saying in the community means literally that the parents become the mental health facility.
I mean, it's a whole other layer of problem.
The thing is that there needs to be those inpatient beds. And the problem is that this bill sets it up where the only pathway to inpatient beds is going to be through a felony, which, I mean, probably already is the case, because that was certainly our experience. But there needs to be that. There's a certain element at a certain time period where people do need that inpatient involuntary care.
Yeah, and it takes more than the 16 days.
It's not 16 days.
That's right.
Yeah,
and that's part of the problem too. I mean, I think I would agree that there needs to be some more beds, but just keeping people there long enough to stabilize and come up with like a discharge plan that actually sets them up for success. I mean, even when I get a certification, it's often like 3 hours. Oh, they're going to be leaving today. It's like they've been in the hospital for weeks. Why are we talking about the certification today? So it's a lot to ask of people.
Well, and if what you say is true, Kelly, and it's the only way you can get it is through a felony, yeah, some of these folks probably are going to have felonies with what they're experiencing, but I think that makes it so you're just criminalizing it, which is like it is. And I think that the hope eventually is to separate those and have it so they're receiving mental health care and it doesn't get to the point of a felony. And this is almost going in the opposite direction a little bit. Felony
So
or
this is,
suicide.
oh, sorry, I didn't mean to cut you off. Keep going.
No, go ahead. I just saw your note, a felony or a suicide.
Felony or a
Yeah.
suicide, yeah. This is one of
We
those
got both.
things I'd love to take a really good note on because what you just said, Karen, I mean, getting upstream, what are the things that need to happen to make the front more successful? You need that information before 2 days before their discharge. So what are
2 days would be that would be that would be so nice. That would be an
usually
eternity.
you get, hey, they were discharged
literally,
Monday.
I know, literally, I get a call in the morning. They're discharging this afternoon. Will you take the cert? And I'm like, are you kidding me? Like,
So what is that entity? Let's peel this back for just a second. What is that entity that if we were to say you are required to pass this information on? I mean, the new bill that's out there says follow-up is not 48, it's 72 hours. We have the ability to put hour marks to things. What is that entity that needs that shift and that mandate?
so the bill that I worked on with a bunch of people on this call a few years ago, I thought it had put in there a 72-hour, like you must give 72 hours notice. And then with a couple of these egregious things happening with discharge of certs, we went back and we looked at it and we didn't see it. So I don't know if that was ultimately taken out. But let's just say, even if it was in there, I think there's been, acknowledgement that that's hard to enforce. That to make the hospitals say they're going to give you 72 hours notice at minimum. So I
Can I
didn't
ask
even
a
like,
really silly question though? They have discharge planners. Why is that hard to enforce? That blows my mind.
Yeah, me too.
You have specific people that are hired with a job description that says discharge planning.
And they don't even, the only reason we know, we have a liaison that works for us. Like, I don't even know what would happen. Like, I wouldn't even know about these certifications if we didn't have a liaison involved. Because they're not calling me or us. Like,
So are these
Yeah.
your 2765 facilities, Scott? Can you speak to any of this from inpatient? Is this
Well,
is this kind of I don't want to throw you under the bus. Is
I
this
haven't
one
heard
of your
anything that doesn't
facilities
sound
that would
totally
fall
right.
into this?
okay. Well,
Yeah.
I mean,
No.
your experience may be different than what I see. with
No.
these
I was saying I haven't
Yeah.
no, this sounds exactly correct. I mean, and what comes up for me is that like the challenge, I mean, and specifically, with this bill, like, there's concern about criminalization, capacity for handling short-term certs. I mean, in my mind, it's like that's kind of the status quo. And so I'm trying to I think I'm trying to figure out in what ways does this make this worse, as opposed to does it create some new opportunities, some beds, even if it's not a 100% improvement. So like the status quo is, I think, busted in many ways. So is this an incremental improvement? And some of the things we're talking about, like letting you know that the patient is discharging, I think that's kind of a BHA question for me. Like, is that the law and the regs now? And are those being enforced and monitored? And maybe that's a regulatory question more than a statutory question. Like, are you letting someone know the cert's in?
Well, we had it in that bill.
Yeah.
1256, I think it was, but yeah, it's not in there. And I mean, we have BHA people on the call, but it was kind of from the BHA, if I recall correctly, that we're saying we can't really hold the hospitals to it. But I don't know if that's true or not.
Well, and that's why I asked Scott. I mean, is this would this be something that would go to all your locked 2765 facilities be mandated to provide 72 hours notice, blah, blah, blah. That was the point of that question.
Yeah, and I forget. I mean,
That was
I forget the specific rules, but there are all kinds of inpatient. I mean, it's like you got to have cell phones, you got to have safety plans. You gotta have,
but these things aren't in there, and also like, again, like it's the enforcement, and the hospitals kind of do what they want, and it's like you can't stop them from letting them from discharging them.
Yeah.
Karen, did you see what just wrote in the chat? It says currently there's a 24-hour notice and requirement for discharge planning conference.
Yes.
A conference?
That's what it says. Discharge
Really?
planning conference.
Yes, there needs to
When
be
was
an
the last time
actual
you
like
had that?
discussion around this person's needs and the transfer of their certification. So if that's not happening, like blow us up with complaints
I was
because
gonna say,
we
how often
can't.
does the mental health center report that? Like,
I mean, okay,
and would you like? Yeah.
It's not getting reported.
Would BHA do anything?
so we were so upset
Yeah.
with this situation. Someone was going to report it. I don't know if it went through, but I mean, this was a patient that had been there for 2.5 months that we were getting less than 24 hours notice on. Yeah. So I mean, even these very basic things, like we can't even get this stuff going, let alone these much larger issues that these bills kind of speak to.
But it's like if you can't, like, if they're, and I guess what comes up for me, and Jessica, I appreciate you saying that, is like if we're not going to, like, there have been all these efforts to improve the quality of care and these transitions, but if we're not going to hold people, like, if there's no effort to stay accountable to what we've put together, and like, you can have huge bills in the future and it won't do anything.
Right. Well,
So-
that's kind of
Well, and what I can say is
Yeah.
from like a regulatory standpoint, when we are going, and it's probably going to be me sticking my foot in my mouth, but just bear with me. When we're going out and we're doing chart reviews, we are looking at the day-to-day care and safety that these people are receiving. So I'll be very transparent, like the looking for the planning conference notes is not high on my list of priorities when I'm looking at seclusion, restraint, involuntary medications. So if we're not being informed that these discharge planning conferences and these discussions are not happening, we have no way to go back and hold a provider accountable because we just don't know. And we're gonna miss stuff in our annual inspections, right? If we're there once a year, we might actually grab charts where they had a discharge planning conference. So the more complaints we can have around these things that are not happening, the more we have some oversight. What I will say is we have multiple psychiatric hospitals right now on adverse action because they're not even doing the safe stuff right now. And that's why I say things like these are where our priorities are lying, because we have people who are being inappropriately restrained. We had someone who was restrained and secluded at the same time. Like we have other things happening that unfortunately are taking priority over the needs of some of like the community-based providers because we're not hearing about them and we're seeing so many concerning things elsewhere.
I think it would be safe to say, since like literally I don't think I've ever gotten more than 72 hours notice, or maybe a couple of times out of many certs. If you looked at the charts of people who are on short-term certification, like pretty much all of them for these notes and audited to that, I think you'd pick up on a lot of things.
I bet you're right. I would say also a lot of our short-term certs end at discharge from a psychiatric hospital.
And is that because they don't give enough notice and there's a way, it takes time. You got to find a provider. You got to do all these setup appointments. You got to get meds. They're often due for an injectable in like 3 days. It's like, I mean, so when they drop it, it's easy to say, well, this is, those outpatient providers refuse to take it. I mean, that's how they make it sound, I'm sure. When it really is like, did you even give them a chance? Did you have a conference? Like how far in advance did you notify them?
Dispo planning, I've got so many patient units. It's mediocre.
Yeah.
I mean, really what they need to do is start planning discharge at intake. And we're not seeing enough of that. They're doing it like day to day, thinking about like, can we discharge this person? Are they ready to come off their cert? And then if they're like, oh yeah, they can totally leave. Then they start planning discharge. Like that's not how it should be at any way, shape, or form.
Where do we get to the heart of who this is affecting besides Dr. Rice, who's sitting right here in front of us?
Kelly's got her hand up. Stop talking.
Sorry, is there a way to send out a survey and gather information?
We probably could.
Yes. Yeah, okay. Sorry, Kelly, the camera's pointing to Dr. Rice.
It's all right. I'm like, wait, it's up, I promise. So the one of the things that I saw from the patient's perspective or from a caregiver's perspective, this goes even further because we would have discharge planning that supposedly took place on paper that never took place in real life. So it was when you go and look at the paper, you might be seeing things that didn't actually happen. Or we were discharged, my daughter was discharged with a note to follow up with a psychiatrist who no longer practices in the state. So that, that shouldn't happen. And so we were left on our own to try and figure out how to get an injectable, which we never did manage to figure out. But things are sometimes existing. It goes even further than just not getting it on time. Sometimes they only exist on paper.
Right.
Yeah. So anyway, I will.
I might be very naive to all of, well, go ahead. Sorry.
No, this is fascinating, and I'm trying to wrap my head around. Let's take this conversation of a very real problem and figure out how to put action points to it. Keep going, sorry.
I was just going to say I might be and am probably naive to a lot of this, but to me, something that comes to thought is, we don't want this to be a criminal thing. We want it to be more of a mental health thing, but there is like a legal involvement associated with it. Like, it all sounds like there needs to be something like parole officers for people who are in this instance, like social workers who are assigned to you legally and they follow up with you and they can help assess you, they can help manage you, they can help make sure you're coming to your appointments, you're getting your injections. They have the legal ability to come get you if you don't show up, right? And so I think and again, I'm naive, but what's stopping us from trying to think about a system where you have essentially parole officers for these sorts of individuals? I don't know how many there are. I don't know the reality of it. I know there's funding that needs to be thought of, but again, I feel like that could potentially be something that would help a lot.
So
Would that be the role of the ACT teams? I mean, that's what ACT is for, but does that cover
I was in
from
charge
the...
of I was in charge of an ACT team for 8 years, and again, the same problems exist. You can't enforce it. So you could assign someone, and that's what ACT largely does. But again, without enforcement, I mean, when you're in the parole system, you're still on the criminal side, and then you risk kind of being the stick there is you risk going back to jail or whatever. And once you move to the civil side, there isn't that same thing. Huh?
There's no carrot, there's no stick anymore.
Right.
Right. So I will say the juvenile justice system that my daughter was in actually does have exactly that. They have I can't remember what they call them when they're in the jail, but when they get out, it's their parole officer. And we actually loved our parole officer, but he would come and make sure that she was doing what she was supposed to, check in with her regularly. So in the juvenile system, that does exist. There still wasn't any care to put her in when he suggested care, but
What happened if they didn't show up for treatment?
she ended up back in jail.
See that? I mean, that's really,
Twice, actually.
yeah. I mean, that's the kind of leverage that you need to get people to follow up with some of this stuff. And once you move it out of the criminal realm, it's hard.
Hey
'cause you
guys,
don't want.
Tasha's been very patient with their hand up, and so if we could
Sorry.
allow them to speak.
Sorry.
Raise your hand. We're not seeing them at all.
We're not
Sorry
seeing
about that. I know I'm not a part of this, but what if, and this is just the workforce shortage that we have, the QBHAs with their certifications involved with I don't know, there's just something with the peer support with that. Does that make sense? I don't know where I'm going with this, but that just was something where we could utilize our QBHAs and peer support for like court liaisons or mental health liaisons with dealing with the system. Larimer County got a really good system when it comes to their mental health treatment and their competency and stuff like that. I can't tell you, I haven't been involved in that, but I just know from doing meetings up here, it might be something to look into. Thank you for letting me share.
That is great. Larimer County has a lot that's working well. I was just up there.
I mean, what's working well for them that we could adopt, you know?
Well, they just
My
opened
sense
a
is,
new facility, but
Mm.
but why did they open it? They have support from the local government. They have a tax
yeah.
initiative, and they're getting a lot of revenue there. It's like there is a community of people taking care of these patients in Larimer County, and they've decided to work together. Like
Yeah.
that's what they have.
Two catch-22s. Number one, we want to standardize everything and make it the same across the whole state, but it's not physically, financially feasible. So that's why everyone does things in their local communities, because the local communities will support their local community. And then the second catch-22 is we don't want to stigmatize our clientele. We don't want them in the criminal system, but the criminal system is the only place where there's teeth. And so you've got these catch-22s as to what is the lesser of the evil. All right, action items. I kind of asked Tom, when I said, who does this affect? And Tom wrote in the chat, it affects everyone. I would love to be able to find a way, and this might be adding a task to y'all's plate at the BHA, but if this really is something that we can try to address, or if it seems feasible to address, is there a way to get the everyone's that this affects and send a survey out and get information, get factual information and say, we've got, 56 responses from providers and here's what they say, and then decide what to do with that. Is that feasible? Again, I don't know who the everyone is. Is that just all psychiatrists that would get a cert pass their way?
Yeah, I mean, I totally agree with the sentiment, Michelle. I guess I'm wondering like how good and valid a response rate can we get in the time frame
I don't know.
That we would need.
I don't know.
Um,
And who's going to track down all the emails and contacts? Well, that's why I said I was just trying to get clarity on who's everyone, because if it's, 2765 facilities, somebody at the BHA has contact info for every single 2765 facility, but I wasn't sure what um, there you go. The Rays and the Bassos.
well, I know every professional society in the space has thoughts too. I know CPS is tracking.
But the problem is our people are caught in the crossfire of being harmed. So at this level, is there, with all that we've discussed, is there kind of an idea that someone would be able to toss out? And maybe it's something you think about and bring back next meeting, but is there an idea or something someone could toss out to say, if we wanted to say we tried to make some improvement in some system, what would that be? What could be done? Again, these are the things that we get to make recommendations for.
Well, I guess from the perspective of this committee, which is a BHA committee, I guess, as I'm just flipping through the fiscal note now, right? There's a lot placed on BHA here, right? Like assuming care coordination responsibility for instances when there's not another community provider. So, I mean, I guess I don't know what BHA's thoughts are on a lot of these, and if this aligns with any kind of current capacity. I mean, maybe our role is to think about like, hey, what are the things that the BHA needs that could respond to some of these community concerns, like unfunded mandates to monitor certs, so on.
Well, a lot of
Unenforced
this like care
discharge
coordination
mandates.
piece that got added, they actually call out OCFMH. Like there's some stuff in there that we said like, hey, this isn't us right now. And it was stuff around like the protective placement in the regional centers. We flat out said like, this is OCR. But a lot of the stuff in 2765 that they added, they were like, OCFMH will do all of this care coordination. So one of the reasons the fiscal note's so high for OCFMH and so low for BHA, because we only added, I think, like one care coordinator to help with some of these new pathways. I don't know if y'all saw it. I know Frank just said it. He dropped some amendments in the chat. There's 3 different documents. I just combined them. They're around 20 pages total. But I think a lot of these concerns that we're bringing up look like they're getting removed. I haven't had a chance to like dig into it. But I'm glad there's going to be a lot of amendments.
I mean, it's, like one of the messages, I know other systems have, taken positions on this bill and maybe oppose, pieces outright. CBHC is an amend position. I think one of it is just, one of the things that happens in this. Let me back up a little bit. So I describe this bill as having two lanes. Lane A is for a very narrow population that was a result of impact of a bill that was passed in 2024. The population is roughly 25 to 50 people a year. It's permanently incompetent to proceed, dangerous, crimes of violence, and they get released, and we need some way to wrap care around that individual. The broader pieces around 2765 were added, I believe, to address the competency issue. But those are the pieces I think that caught many stakeholders by surprise. Many stakeholders are saying, just take it out altogether. CBHC is in an amend position. We were saying, if you're going to keep some of these things, this is what we need to make it work. Put some more discretion, recognize discretion, clinical discretion over, for providers. We share some of the advocacy concerns around civil liberties and patient protections. But if you look at this list, there's potentially new proposals happening as this bill has already been introduced that won't be considered until after the first hearing. And so, just on a process basis, it's like these are very significant proposals that should not be rushed. Just by the example of what it's trying to fix, every time you rush something and you don't think things through, you end up having to come back and clean things up. And so just from a process standpoint, it seems reasonable to say, let's set these pieces aside, focus on fixing the problem that was created by the bill in 24. And, maybe to your point, Scott, like what, using like thinking about this advisory board and the BHA's oversight over the system, like, is there something that can be put in place to bring stakeholders together to work through these issues? I almost like I don't necessarily love the idea of a task force, but I think about something similar like the CCJJ over criminal justice, where you had a table where everybody was represented and most ideas had to go through that committee and get deliberated before they got, sort of, stamped with, consensus or, majority support, and you actually got to vet the ideas, where you had all stakeholders again at the table. So I just think many of these things over the last few years have been rushed and have not been done thoughtfully, and we continue to have to go back and fix things piecemeal. And anyway, that's a comment on the process over the content we've been talking about today.
So
So
notice
Jess, you
number
said the
one.
BHA took an amended, sorry, you said the BHA took an amended position on this? We'll just have to watch it. See what happens. Sorry, go ahead, Kelly.
So number one on your amendment is pull back some of the bill's original expansion. So is that going back to just looking at creating a new pathway for IDD and TBIs? Is that because that I think was the original, is that there was a problem with the pathways was only for mental health and that it didn't cover these two other people who have competency concerns. And so is it going back just to that? Is that I haven't read the new one because obviously they just amended it.
Yeah, they haven't amended it yet. And so what's going to happen this afternoon is they're going to take testimony only, continue to work through amendments, let the budget pass in the Senate, figure out where the money is sitting as they continue to work on the fiscal note. So no amendments are going to be offered today. What, yeah, I mean, I can let Jessica speak to the department amendments, but this package of amendments has been shared. The summary that I have is just AI generated, trying to break it down, trying to break, 22 pages down for this group to even be able to digest about what's potentially coming. But yes, to answer your question, a significant portion of changes on 2765 will be pulled back, but proponents are offering a new pathway that has not been stakeholdered yet, which again is part of my concern on process. But I don't know if Jessica's got anything to add there.
Sorry, I had to step out. What was the question?
I think it's just clarification around, maybe what we're seeing in the amendment package versus, what the BHA's amendment position looks like.
And I had dropped in the chat. So BHA also took an amend position to remove everything from 2765, essentially, even like the stuff that they added to 108.1 through 108.4, to basically remove it and make it its own section. Because I haven't had the chance to look through the amendments yet. I don't know what that's going to look like in these amendments, and I don't know if we're going to continue to request amendments based on what these drafts look like. So there's about 15 minutes left. I do need to jump off. Thank you everyone for your time. I will turn it over to Michelle if we want to talk about anything else.
Thanks, Jess. Good luck.
Thank you.
Anything else on this enormous topic?
Like the bill to reform the mental health system in Colorado is what it feels like.
Right?
Let's just fix it all.
It's really funny. I was just writing a paper and going back and rather than pulling from memory, researching the Community Mental Health Act and what it was put in place for back in 1963, right? And going through the big visions JFK had that never seemed to come to fruition. It's kind of like, you're right, that's what we need, a total reform of the system. Oy vey. What was the next agenda item? I think that's all of our agenda items, yes, but I don't have the agenda up in front of me. Ashley, would you mind pulling it up really quickly, please? I closed mine.
One moment, please.
I closed mine for whatever reason. I do think that was it. The last thing that was on there was the continued conversations about our EC and M1. That's just another piece that's going to keep happening in this mental health system conversation. That's the discussion on the competency bill. The other discussions we're going to keep having, because they will continue to come up, is, as we discussed last time, the EC statute is 3 pages long. It has not been touched, amended, updated, or really reviewed since 1973. So there's a lot of push for amending that. And in doing so, the idea came up to just combine it with the 2765 statute, which, as we all know, is not that simple. And so we had a really robust conversation about this last time, and we're going to keep doing that because this will be part of our recommendation to the commissioner at the end of the year. Anything from last meeting that folks thought about when they left about this combining EC M1? Those of you who were not here maybe last meeting and have any thoughts on the EC statute, the M1 statute? pros and cons to making them one case statute, get rid of the E and the M and start over. Next time we will review the minutes and kind of summarize what we talked about. Maybe folks can pull from there to move forward. We also have some targeted questions we were coming up with as well. So anything else for this group? Those of you who joined as a visitor, we love having you. Please continue to come back. You can see our conversations get pretty robust. Anything else? Otherwise, you get 12 minutes back in your day and y'all get to go on your tour.
Michelle, do you want to do the formal opening for public comment?
Oh, yes, of course. Sorry, that's what I was doing. I just wasn't calling it public comment. There is a formal time for those of you who have joined to make public comment. Do we have anyone who would like to add any comments? Thanks, Tasha. Keep those gears working. Come back next time.
Thank you guys for letting me be here. I appreciate it.
Absolutely. We appreciate your input and thoughts. And just as a quick note, this is not a formal group under anything except the governor. So we really don't report to anybody except that chain directly up, making recommendations to the commissioner. And that's why this board is full of people from so many different sectors: inpatient hospitals, outpatient, lived experience, private sector, so on and so forth. So it does allow us, like I said before, to have a really robust conversation because we all see things through our respective lenses of our day-to-day functioning. Frank, you are always such an amazing person to have with your expertise and your vision and through your lens. So again, thank you for always coming. Any last comments? Otherwise, our next meeting is May 11th. We will resume our virtual and we're going to do another hybrid in person in the fall. But if there is nothing from anyone else, I will adjourn us at 10:48. Thank you all for coming. Those of you up at Anschutz, have a lovely rest of your day. Enjoy your tour.
You too.
Absolutely. Everyone have a great week and we'll see you next month. Tasha, you're awesome.
Thank you.
Survivors are great people.
Yep. Thank
Have
you
an
so very much.
amazing day. Y'all take care.
You as well.
Bye-bye.